Very good morning to all of you. At the outset, I'd like to thank Dr. Mahendra for inviting me here today. I'll be talking to you on the need for extensive, expansive, elaborate laboratory tests and modern diagnostic assays. Advances in medicine and technology have seen the emergence of many new investigative modalities, making it tough for the ophthalmologist to decide what to test. We have various tests available to us: the platter, the skin test, the serological test, the imaging test, the biopsy specimens, and molecular diagnostic tests. However, we need to tailor-make the investigations for each case and zero down the diagnosis. We need to remember all the tests share the false positive and false negative. We need to understand the sensitivity and specificity of the test when we are doing the interpretation. Coming to the indications for the extensive workup, whenever we have suspected infective uveitis, or if we have atypical presentations or presence of multiple infections, the patient is immunodeficient, or atypical presentations in extremes of age group with suspected masquerade syndrome. The polymerase chain reaction is a powerful method to amplify the small specimens of DNA or the RNA. We can do it with the minimum volume. Now, next generation sequencing has come into the armamentarium to find out the exact. It's used both in infectious uveitis and also in masquerades. We'll see some case examples. Here is a 51-year male presented with defective vision. He gave history of COVID vaccination, following which he developed pericarditis. He was in home isolation. He was treated with monoclonal antibodies. He was complaining of low abdominal pain with multiple episodes of colonic bleed. Visual acuity was normal. Anterior segment examination showed prominent corneal nerves with AC reaction in both eyes. We could see the fine keratic precipitates, both right and the left eye. Fundus examination was absolutely normal. Confocal microscopy showed owl-like pattern of keratic precipitate. Usually it's been described with CMV, anterior uveitis. Specular microscopy shows polymorphism in both eyes. We investigated in detail in view of colonic bleed. Systemic investigations, including the PET-CT, was normal. Serological test for CMV IgG came positive. Empirically, in view of owl-like pattern and the systemic features fitting into the possibility of the CMV infection, we started the patient on topical vanganciclovir gel. ACTAP came negative for CMV. The CD4 count was normal. Colonoscopy was normal. Systemic conditions started improving on its own. Following ganciclovir therapy, we could see the resolution of the owl-like pattern and normalization of the endothelial cells. So we do suspect, even if the investigations are negative, we go ahead with the clinical picture and treat the patient. This is an example. Next case is a 41-year-old male presented with blurring of vision since 2 weeks. History of fever 4 months ago, which was gradual and painless and progressive. Anterior segment examination showed pigmented keratic precipitates with AC reaction in both eyes. This is a fundus examination, where you can see the media was clear, multifocal retinitis with retinal hemorrhages. It's suggestive of necrotizing retinitis. Suspected CMV infection. OCT shows full thickness retinitis, both eyes. We asked the patient in-depth history: prolonged fever, weight loss, loss of appetite, history of any intake of medicines, and previous history of hospitalizations. Bluntly, patient denied to all the history. Even though we suspected, looking at the fundus, the possibility of a CMV retinitis, he said, I recently relocated from Chennai. That's all was the answer from him. But we suspected CMV in him. We investigated. To our surprise, HIV1 and 2 came negative in this patient. But we went ahead and did the ACTAP, came positive for CMV, correlated with the clinical condition. CD4 count was low, 163. See, we clinically picture looks HIV. The patient says no systemic history. Serological came negative. We started empirically patient presuming it's a CMV retinitis and started the patient on topical, intravitreal and systemic ganciclovir therapy after clearance from the infectious disease specialist. Then again we probe. The patient comes this time, disclose the past history of retroviral positive. Right now he's staged into stage 4 AIDS. Advanced stage. Because of that, his serological titer is negative and he has taken ART for 8 years in the past. Now he stopped, he is on SIDDHA treatment. We advise the patient to restart the anti-retroviral therapy. Patient received intravitreal ganciclovir, 5 injections so far, and we could see the resolving retinitis. Unfortunately, we are able to maintain the reasonably good vision so far. So this particular patient clinically looks like HIV, picture looked like CMV. Commonly, we order antibody tests for HIV 1 and 2, which came negative. So here, this is a globe. When you have HIV, during the window period, we can have negative, and we get the antigen positive and followed by antibody. When we order 4th generation test, it can detect not only the antibodies but also the antigen P24, which can be detected 18th day of the window period. So this test may pick up both. So our patient showed HIV 1 and 2 negative. Why? It could be true negative or false negative. In our case, it was false negative. Whenever we do a testing in the window period, or if the extreme late stage of the disease as seen in our patient, or in treatment with the intensive phase during the acute phase, it can show negative antibody titer. It's important this case to show that even if the HIV 1 and 2 is negative, we need to go ahead and chase the cause and treat the patient. The case 3, similar to Dr. Samendra's case, 61-year male, it's a reverse, came with diagnosed of a postoperative uveitis, treated with topical steroids and did not respond. And he was also a known case of CNS lymphoma. He was treated for the same and currently is under remission. So this is a presentation. The patient had fine keratic precipitates in both eyes. At the time of presentation, we could see the white anterior vitreous cells. Whenever you see this kind of a cells, this is commonly seen in intraocular lymphoma. Our antennas have to go up. So this is a fundus where you can see the diffuse media haze with vitritis. OCT shows vertical hyperreflective lines. This could be the early biomarker for intraocular lymphoma and deposits. We went ahead and did the systemic workup was negative. PET-CT did not reveal any lymphoma. ACTAP was negative. Vitreous biopsy negative for lymphoma cells. So we closely followed this patient. On 5th month of the follow-up, again presented with AC reaction. Confocal microscopy showed floral pattern of keratic precipitates, which we have described as an imaging biomarker in a case of intraocular lymphoma. This time the patient had both complete and incomplete floral pattern. Vitritis and vitreous haze was there. This time, in addition to the vertical hyperreflective lines, the patient developed sub-RP deposits. This again is an emerging biomarker for intraocular lymphoma. So we did it with the repeat vitreous biopsy, came positive for intraocular lymphoma. CSF also showed positive for malignant cells, and this patient was started on intravitreal methotrexate systemic chemotherapy and intrathecal methotrexate therapy. So this is prior to the therapy, and this is following 5 intravitreal methotrexate injection. We could see the disappearance of sub-RP deposits. Same thing happened in the left eye. So here our patient had white keratic precipitates, anterior vitreous white cells, floral pattern of keratic precipitates, vertical hyperreflective lines with sub-RP deposits. These are imaging biomarkers for intraocular lymphoma. The next case is a serpiginous-like choroiditis. As we all know, in Indian we attribute secondary to tuberculosis. But this particular patient had toxoplasma serology. The PCR for toxoplasma was positive. We went ahead and did the blast analysis, confirmed to be a toxoplasma. So we treated the patients with antitoxo and steroids, responded well to treatment. So here we reported serpiginous-like choroiditis can occur secondary to toxoplasmosis in addition to tuberculosis. Do we have a time, or can I stop if I am exceeding? Yes. This is the last case of a 56-year-old male presented with redness and pain in the eye. He also gave history of neck pain, morning stiffness at present. This is a clinical photograph showing diffuse episcleral and scleral congestion. So this is a close picture of the scene. We all agree the patient has scleritis in both eyes. Fundus was absolutely fine. B scan also was normal. When we investigated systemic evaluation, the patient had nail bed infection. He had infection 1 month ago and treated with systemic antibiotics, and he also has resolving malar rash on the chin. So we restarted the patient on oral antibiotics and metronidazole and taxim. This is systemic evaluation. Most of the infective workup is negative, anti-CCP negative, procalcitonin was done in view of nail bud infection, ANA and ACA profile was negative. So within 10 days we could see the disappearance of the congestions. However, we could see the whitish, this close picture will show the lesion underneath the conjunctiva. This suggests the possibility of an infiltrative pathology. So went ahead and did the IgG4. For surprise, serum IgG4 levels was elevated. We referred the patient to the rheumatologist, started on systemic steroids and systemic immunosuppressive therapy with methotrexate. This is 4 months follow complete resolution of the lesion. So here infection is a trigger of underlying autoimmune uveitis. So whenever we ask the patient before ordering the test, will it identify any underlying specific systemic disease process or associations? Will it provide definitive etiology, or is it going to confirm or reject the diagnosis, or is it going to help the management of the patient? We have to ask these questions before ordering any expansive investigations. To conclude, a detailed history and thorough clinical examination still remain the most important diagnostic tool. Avoid investigations that do not either assist finding the cause or management of the condition. We need to tailor-make the list of investigations according to the clinical picture. Order expensive tests only if the clinical picture demands or the condition is refractory to treatment. I would like to acknowledge team members. Thank you for your attention. I take this opportunity to invite you all for this UCCon 2023. This time along with UBRI, it's going to be in Abu Dhabi. We welcome you all. Thank you.